Alfredo, thank you for joining us. Sorry, there was a few
Hello,
technical
everyone. How
issues.
are you?
I think we're still trying to get Mario on board. Mario, if you're watching, if you could send a request to join, that might be better than me sending you an invite. So if you could try that, and then I'll try and add you. So you're joining us from Colombia today, are you,
Yeah,
Alfredo?
I'm in Bogota right now.
Great.
It's quite interesting what you were talking about, because I think one of the things that is important for us when we deal with men is that they are very private. They don't want anybody to know that they had surgery. And sometimes for facial surgery, it's even worse because when you have recently done the surgery, it's very noticeable. So everybody knows. So literally, they prefer to hide. They prefer that nobody knows anything about it. They are very aware that they don't want even their friends to know because right now still we have this stigmata, this kind of bullying that happens when you do surgery as a man, which doesn't happen with women, in on the contrary, when we have women in Colombia, for instance, or in Miami and some other ambience, especially Latin ambience, you do surgery because you can afford it. So it's literally something that is pride. They are actually proud of doing the surgeries. So men, they don't want anybody to know. They don't want even the friends to know because it's especially heterosexual male. They are very afraid that they're gonna say, "Oh, you're now behaving like a gay. Are you becoming gay?" These kind of stuff are like one of the things that actually affect men in their psyche.
Mhm. I think that's
Hi,
very
Mario. How
interesting.
are you?
Hello, I'm fine. Hello, Alfredo,
Mario.
Ez
Finally,
and Nora.
we've
Such a
got you
delight to be
joining
here.
us.
Sorry, I had
Amazing.
to enter with my wife's account.
Okay.
Mine was not enabling. Sorry for that.
Yeah, I'm not
Happy
sure
to
what
be
was
joining.
going on there. Thank you for joining us this evening from Portugal. Um, I think what we'd like to do is to talk a little bit about the kind of procedures men are having, and we've got an amazing panel on body contouring. So I think the focus on this area would be amazing. And Mario, if you can sort of share with us, I know you've done some talks on safety optimization in terms of the procedure in male and relate that to the male patient. So if you can give us your approach to how you consult the male patient, what you do differently in terms of the male patient compared to a female patient, and then give us some nuances in terms of the procedure.
Yeah, sure. So I was listening to what Alfredo was saying, and I think the reality between male patients and female patients is quite different. So also in my experience, most male patients are a little bit more conservative in terms of saying to other people that they went through surgery. So this is a major concern, which needs us to raise the level of our own results. And this is actually a good thing because the idea nowadays is to try to make the surgery as natural as possible. So that's the challenge. That's the rule of the game today. And especially in Europe, we have to adjust the degrees of definition to the aesthetic ideals of the patient in terms of naturality, but also considering the characteristics of the lifestyle of the patient, and that's a big challenge for us surgeons. Most of the patients come to my office most of the time, asking, for example, to solve the gynecomastia, which is more common after 40s, or the lipodystrophy of the abdomen and flanks. These are major complaints on male patients in terms of body contouring. So our job nowadays is to try to educate our patients and make them understand that instead of just a traditional option of treating the specific problem that the patient has, nowadays we have the ability of changing the full torso of the patient, therefore achieving a much more natural overall result. So instead of the deformities that traditional approaches to gynecomastia, for example, or to the liposuction, isolated liposuction, or of the area of lipodystrophy that we did in the past. Instead of having these signs of surgery, if we approach the male patient as a whole and we treat the dorsum, the anterior part, and the arms all together in an aesthetically sound way, we head to a more natural result that then will not be noticeable, and it's more pleasing to the patient. So, in my perspective and in my experience, the challenge nowadays is to try to educate the patient that comes to you with one or two isolated problems, and make them understand that the tools that we have nowadays can enhance an overall result, but this requires a global approach and not an isolated treatment of isolated anatomical area.
And I think you've hit the nail on the head there. I think one of the key issues, certainly in the UK, and I don't know, Nora, if you agree with this, is that patients, when they come for their consultation, they're all focused on just one area. So they're only thinking about the gynecomastia or the tummy. And it's very difficult to try and talk them into realizing and educating that actually, if you look at the body as a whole, if you treat just one area, it will look quite different from the rest of the body. So what do you do during your consultations, Alfredo and Mario, in terms of educating them, and how do you convince them then to actually consider the body as a whole?
Well, it's quite interesting because what we have right now is that we offer them a solution that is all or nothing. Usually I talk to them about this. I tell them high definition is not to do the arms and not doing the pecs, because they're not going to match each other later. If you don't do the abs at the same time, so it's gonna look a little bit awkward. And this is one of the things that is very important for them, is that they want to look natural. And I actually go that way precisely to address the whole thing. I tell them, okay, if we only do the arms, you're not gonna look natural. We only do the pecs, you're not gonna look natural. So the idea is convincing the patient is more the labor of doing the education, the proper education. And what we do is, of course, the problem is that maybe they are used to do this kind of sectoral like the section, but nowadays the whole compendium is to do one-stop shop, and we can do one thing at one in a single procedure that can do everything that they want, and they actually love it later. So usually it's part of the education of the patient at the beginning, but later the patients, when they start seeing other patients and they start to seeing the results, they say, I want that. I want to look at that. So if you have to do everything, let's do it.
Great. I think we've just had a comment. I don't know if anyone's got two devices on, just because there's a bit of an echo. So if you could just
Yeah, I
stand a
think the
little.
problem is that we need to have headphones, all of us. So if you have some return of echo, it can be because of the headphones or to having two devices at once.
Okay. Mario, have you got two devices open? Because I think it sort of started when you joined.
I don't, but I don't have the earplug, so maybe that's the thing.
Yeah. Okay. Maybe
But
turn the
yeah,
volume down a little bit. That might help a little bit.
Okay, I will. Let me. Did this help? Maybe.
I think it has.
Yes.
Yep.
Yeah, it has. Yeah.
Okay, cool.
Amazing.
Perfect.
Cool. So, I mean, I had the privilege of joining you both in Portugal about 2 years ago, I think it was, at the Total Definer course. And I think that was quite eye-opening for me to see that total body transformation. And as I said, I think it's educating people that actually you need to look at it as a whole, because if you just do an isolated area, it's going to look completely out of place. Nora, have you noticed this as well in the UK? I don't know if it's just a UK thing.
Well, certainly with me, patients come in asking about one area, but they have to understand that everything's in proportion to the next area, and each area is influenced by the surrounding areas. So you ultimately you want a patient that looks natural and that looks their body is in harmony. It doesn't look disjointed, that with one area treated, another not. And I think it's about education and explaining, as Alfredo and Mario have said, so that everything looks like it belongs together, not having one area out of sync with the surrounding area. And I think patients understand if you explain how perception and proportion are influenced by this. I think they generally understand and realize why.
Now, can I ask you, when a patient walks in, I mean, what would you say is your ideal patient? Which is the patient that you would just run away from? So, patient selection.
Yeah. So I start before the consultation. Actually, I've set out the parameters, and this isn't just for male patients; it's female as well. When they inquire, initially I send out, as part of the inquiring information, the basic health parameters that they have to meet. Like, for example, no smoking, BMI within a certain range. If they have health conditions, I need the information to come with them. So I start with patient selection at the inquiry stage. And actually that has helped enormously, because patients who know they don't meet those criteria, either they don't come, or they come when they're ready, or sometimes they will call up and say, can we, I know I have this, but can I come anyway? And that's okay, as long as because then they're already primed that I will want something else done before I'll offer surgery. So starting before the consultation makes a huge difference. It also narrows your clinic down mostly to patients who are ready for surgery.
And you mentioned BMI there. What is your cutoff for BMI? And if I can ask that to Alfredo and Mario as well.
My BMI cutoff is 30, and that's broad strokes. Obviously, the closer to normal, the better, but that's the BMI in my practice, that's the cutoff.
Okay. Mario?
Well, in my case, this is the kind of procedure that you have to have the right patient and right patient's mindset. So it's not a surgery for everyone. So one of the most important things for me is to select a patient that has a stable lifestyle in terms of diet, exercise. I don't want patients that are so eager to get surgery that they go under diet regimens to lose weight, or they started the gym 1 month ago. So I try to avoid those patients and try to make the patients understand that this is an adjunctive procedure through a previous mindset that targets you to change something in your lives and invest in yourself. So if the patient has a stable lifestyle, if the patient has a stable weight, regardless of the BMI, in my case, these are the patients that I will look for, okay? Considering this, then I see the patient, and I hardly rely a lot on the BMI. I look to the patient and I try to understand if, with the amount of fat that I see, by preservation of fat and not throwing fat away, can I get a good result or not? Okay, so I try not to do liposuction. I hate liposuction. Always have, always will. So I think that the idea of taking out fat, which is an organ, and throwing it away is an amputation of this organ. So I try to preserve an organ that is fat tissue. As long as I can deal with the amount of fat tissue that the patient has and readdress it, remove it from the areas that I don't want, and replace it in the areas that I want in terms of proportion and function, like the intramuscular fat grafting in the male patient, you can readdress a lot of fat to liters of pure fat you can readdress in the muscles of the body, thus increasing and benefiting the proportions of the patient and having a very nice result without throwing fat away. For me, this is more important than the BMI alone, because sometimes you have a patient that for the same height has an increased weight, and this is due to the increased muscle mass, and this can be quite frequent in the sportive male patients. So more important for me is consistent lifestyle, stable weight, and then avoiding the comorbidities that can increase the risk factor of the specific patient, considering it in terms of overall safety, in terms of I try to avoid smokers, for example, heavy smokers particularly. We nowadays have ways of managing these risk factors by pre-op and post-op management, like using the hyperbaric chamber or adjusting the levels of iron supplementation. And on this, I think there is an important point to be made, because there has been a lot of scientific production, and we have one of the responsibles here, Alfredo, is producing a lot of articles concerning safety measurements. So nowadays we have a lot of research on this, because these are long procedures. They usually take 5 hours, and to ensure that we are delivering the best results with the highest standards of safety, then we have to control a lot of things. And nowadays we understand a lot about safety in plastic surgery, and this is due to the contribution of the latest advances in body contouring. So if we control the risk factors, if we have a stable lifestyle, if we have stable weight, and if I will be able to preserve the fat tissue, I will go for the surgery. And then the last part to end up is realistic expectations. I have to operate a patient that is compatible also with my own aesthetic taste. Otherwise, there will be a mismatch and none of us will be happy.
Great.
Perfect.
Alfredo, who's your
Okay,
ideal
so
patient?
so I think in conclusion, I do BMI below 32. I think they have a little bit more, like a little bit more room, because the dermis is a little bit thicker, so you can gain a little bit of skin retraction more than a female. Usually female, our cutoff is 30. The second thing is something that Mario mentioned, and is very important for us, and is that is the right patient, that is the right candidate. Usually patients that are addictive personalities, usually the heavy smokers are addicts. They're addicts, so usually we try to avoid these kind of patients, because they are patients that are not going to follow the rules. They're not going to follow directions. In that sense, we try to keep up with the what we call the considerations of the realistic expectations of the patient. So it does happen more in female patients, but we see sometimes male patients that have unrealistic expectations. And I want to look like Arnold Schwarzenegger, and they come with the picture and stuff like that, and they haven't been a day in the gym. So in that sense, I think the motivation that they have is also important for us. The patient that comes with the wife and the wife is doing the talking, this is a red flag for us, because he maybe not has the proper motivation for doing it alone. Usually the patient that comes alone and said, I want to do this because I want to do it for me. I started to do this. They see some changes in their lives. I think there are two main sparks that men have during the years. Usually in the 30s, they just start, you can see the patient that is starting to work out, they want to improve. And what they see is that they are not advancing, so their healthy lifestyle, they actually eat well and everything, but they say, no, I'm stuck here, And we have the other types of patients that, is the 40 plus patient, maybe 50 plus patient. That is the patient that sees that he's already going backwards. So I used to be very fit. I used to do this. Maybe I overworked. I was under a lot of stress. And now what I see is I cannot get back to what I was, So usually we accompany the patient not only with the surgery itself, but usually is diet counseling, and the lifestyle. Sometimes a lot. I think in men we have to take care of the stress factor, because usually men are more worried about how soon can I get back to work. If you ask a woman, they have a very different psyche. When I am gonna be okay. How long does it take to recover? So they actually follow directions more easily than men. Men is like, I need to go to work in 3 days. Can I make it? You know. So I think taking a little bit of brainwash out of them in terms of I need to get ready because I need to go back to work. That's the non-compliant patient. So I tell them, right away, okay, you need to take a week off. No, you can answer the phone, you can get into a laptop, work a little bit, but the thing is, the stress levels, the cortisol levels are not going to help you to get the proper recovery. So those are the patients that I say no to. Patient that is at this kind of addictive personality, the patient that has not the proper communication or not the proper, um, uh, I would say, the proper motivation for doing the surgery, and the patient that is under a lot of stress, that is not going to follow the post-op care and is not going to recover quickly.
Mm-hmm. Now, in terms of, I'd like to sort of focus just a few moments on the pre-op. So obviously now there's a huge increase in the number of patients taking weight loss injections. Do you have any specific guidance on that? Use of anabolic steroids, which, a lot of these male patients, bodybuilder types, may be taking recreational drugs. And again, smoking, what's your sort of guidance in terms of stopping smoking?
That is interesting, a very interesting question. Usually we try to make the patients that are like heavy smokers to reduce, usually when they have one pack a day, they have be at least 2 months, and usually reduce not to literally close to not having anything, because they're not going to comply to this, but at least having less than 10 in the first month and less than 5 in the second month. Usually we accompany it with hyperbaric, and usually we accompany it also with IV therapies. We actually believe a lot in antioxidants and IV. We call mega doses of vitamin C that actually can help with the recovery as well. We actually put them in collagen supplements even before the surgery, because they have less recovery in terms of the collagen production because of that. The second one is the patient that is in reducing or losing weight drugs. Usually these patients already are in a struggle. Usually what you have to seek is who is actually telling to use them. If it is something that is guided by a doctor with a responsible way, or is just something that they found in a pharmacy in a corner in a shady way, and they pay twice the price for doing so. Because LGP1s actually help the patient. Yes, they decrease the insulin resistance. Yes, but they have several indications that actually are contraindications for the surgery. So they slow the emptying of the gastrointestinal motion. So there is an interesting article that actually showed that these patients can have 18 hours of fasting, and they still have some fluid and some food in the stomach. So usually the recommendation is to stop it at least 2 weeks before the surgery. And this is something that we never think about. These patients actually have a very slow gastrointestinal movement, specifically the emptying of the stomach. So it's something that we have to take into care when we are dealing with these patients. The other patient is the patient that is using hormones, specifically steroids. Usually when they're using these kind of steroids for building up muscle, they also have an increased risk of having thromboembolic events. So, and it's a very, very sound, is a very real threat. So usually we encourage the patients to actually stop at least 3 months before the surgery. And the recreational drugs, of course, the idea that they stop them, is the problem is that they actually are truthful to you to say, okay, I smoked this and I already stopped. There is nothing worse than a patient that can, that the night before went to party. Usually cancel those patients. But it's interesting that these patients, you can see that these patients have no connection of what is happening to them and the rest that is associated with. So usually it's, oh, no, nothing is going to happen, doctor. I do this all the time. This patient is the patient that you should cancel.
Okay. Now, I think a lot of people will be interested in sort of knowing more about the procedure and details of the procedure. And I think, Mario, you alluded to it earlier, in that I think there has been a move from just extraction of fat, but now there's a big move of injecting fat strategically to get those contours and definition. How's your practice changed since I saw you about 2 years ago to now? Because I know when we did the course, there wasn't much in terms of rectus injections and things like that. But now I think there's a lot more of that happening.
Yeah, that is. And this relates, I think, in two different final objectives. One is an aesthetic one, to try to get the best results in terms of naturality, that you don't look like you've been operated. And the second one is in terms of function, to make the result long lasting without the development of secondary lipodystrophies, and a result that can cope with changes of tissue laxity that are due to age and slight variations of weight without compromising the surgical result. And for me, the rule of the game nowadays is achieving the right balance in between a technique that was developed by Alfredo, the HD lipo, which means to debulk the deep fat layer and create negative spaces in the superficial fat layer, which means doing a true sculpture of the fat in the superficial layer that will enhance the underlying anatomy. Doing this, but also increasing the volume of the muscles per se with the use of fat grafting. So intramuscular fat grafting has been also a game changer. So the right balance is, where can we place and sculpt these more static negative spaces? In which areas are they gonna be long lasting and producing nice results? And how do we combine this with the increase of volume of the muscles with intramuscular fat grafting? And how to do this in a safe way? So nowadays you can reliably inject fat in muscles like the pectoralis, the deltoid, the biceps, the triceps, latissimus dorsi. These are all muscles that when you increase them, you achieve a V-shape torso, which is a more masculine torso. And if you see pictures of normal athletes along their lives, even when they are 50s or 60s or 70 years old, if they have volume in these muscle groups, they still look natural and they still look athletic. So these are the muscles that you are going to treat and increase in terms of volume. So intramuscular fat grafting has been a game changer. So I'm trying to think a lot about areas that will be consistent over time and that will cope with the tissue laxity that you will eventually gonna have with the aging, and try to balance this with increase of size of the muscles. Also nowadays, ultrasound has been extremely helpful in terms of doing these procedures in a safe way. So nowadays, for the plastic surgeon that does body contouring, is absolutely essential to learn how to work properly with the use of external ultrasound. By being comfortable with this technique, we can ensure that we know precisely the place where we are placing fat, how to avoid the vascularization of the muscles, thus increasing the safety parameters that are necessary for this procedure. And by placing this inside of the muscle, we have the insurance that when the muscle is contracting and when the torso is rotating and when the arms are flexing, that all this is sound, that we don't have bulk increases of volume that are not natural. Because if the fat is inside of the muscle, it will behave dynamically as the normal muscle functions. Okay. So the big change between, I would say, 2 years when you were here in Porto to what I'm doing now is strive in every surgery to get the right balance and try to tailor this balance according to the specific patient. We can have like protocols of uh, smooth definition, medium definition, extreme definition. These are guidelines that you have to master. And then after mastering these guidelines, you have to deconstruct them a little bit to try to tailor this into the specific patient that you have. Okay, because each and every one of us has slight differences in terms of anatomy. And when you get the things right and this balance right, then you get absolutely natural results, which are really long-standing. So the final part of the piece of the puzzle here is the how to control the quality of the tissues in terms of retraction, because we are removing an amount of fat from the subcutaneous fat layer, okay, specifically in the abdominal region. We can balance this by increasing the volume of the muscles of the abdominal wall, and this is a game changer. And we use this with ultrasound, the technique of Ugraft, and we can extend this to the oblique muscles, to the transverse muscles, but we are still facing a problem in terms of tissue laxity, and that's where technology now comes, and we
We'll
really
talk about that in a bit.
yeah, we really have nice tools on this,
Can I?
but maybe this is a full question that you want to
Yeah.
address.
So we had a question from the audience actually. Someone was asking, is it safe to inject into the muscle? Because we all know about BBLs and injecting the muscle and how there was a move from injecting intramuscular to superficial. How is it different in terms of the upper body and the torso? And is there risk of, embolic events with what you're doing? And have you seen any?
Yeah,
Well,
so
that's a very interesting question.
yeah, Alfredo is the one to
Yeah.
to answer to that. Yeah.
Well, the idea is that we have followed our experience more or less in more than 20 years of doing this. We started doing intramuscular fat grafting in 2008. So we started with the deltoids and the pecs, and the idea was that we started to progress into other several areas of muscles. What is the importance of this? The target muscles are what we consider the definition versus what we call the power muscles. The power muscles are the muscles that, or in men, are the upper torso ones. That the more we increase them in volume, the better the man is going to look. So we started with those ones, and we started to do a process of thinking in how to make it safe. So we started by doing, okay, what is the anatomy of the muscle? What is the vascularization of this muscle? What is the approach that we should get to get into the area that we call the target part of the muscle? What is the biomechanics of the muscle, and why are some muscles that are not safe? Specifically, the area of the gluteus maximus has to say is more the exception than the rule in terms of the safety, because it's a muscle that behaves very differently biomechanically than other muscles. So that actually makes it a very dangerous muscle. Having said that, all the muscles that actually are following certain path in the anatomy, that is literally following from here down, from the gluteus all the way down the femoral vein, are muscles that in close relationship to it can actually get involved into getting a fat embolism. So first of all, the idea is to avoid these kind of muscles. Specifically, we actually talked about the adductors and the vastus medialis as the muscles that are very close to them. Uh, the idea of the other muscles, specifically the upper torso muscles, they behave very differently in types of biomechanics, because they don't have the pump mechanism that the lower body ones actually have, that is a valve, a very, very efficient valve system, and second, a very strong fascia that is actually covering the muscles. That's why they're called the second heart. So with that in mind, we have to be more careful of anything that is in the lower extremity. In the upper extremity, these mechanisms don't exist or are very, very weak. So that actually made us, we actually did a series of 3 articles about following all of these muscles, specifically the muscles in the arm, deltoids, biceps, triceps in one article. In another article, we did the pecs. In another article, we did the trapezius and the latissimus dorsi muscles. And we just published an article about the central portion of the back. Later, we are starting to progress into smaller muscles, specifically the serratus muscles and the upper obliques, and the considerations in terms of the geograph, the rectus abdominis muscles, and the internal obliques as well. So having said that, we actually developed a system that is what we call the FAF5. And with that, we have more or less the map that we need, the roadmap to follow a muscle and say, okay, this is safe, is efficient, is going to be effective. And with that, we actually following another classification that we're going to publish soon, that is what happens with a muscle with a specific approach, and also with the ultrasonic guidance. So we're mixing these two things together, the anatomy and the ultrasonic guidance, to see if we can come up to a classification that tell us specifically if this muscle is better or not than the others. So this is something that we're going to publish soon. So in conclusion, most of the upper torso muscles are quite safe. In the lower torso, the muscles that are safe are mainly the vastus lateralis, the rectus femoris, and the gastrocnemius in the sense of vascularization. The gastrocnemius and the soleus are a different type of muscles because they have a different type of complication. And it's the increasing of the pressure inside the cavity, inside the compartment, and create a compartment syndrome. So it's a very different kind of complications, but it's something that we have to have in mind as well. So there is another article that they're working on that is actually measuring the pressure in the compartment in several points of time, like every 5 minutes, and to see what happens with the pressure in the compartment with increasing amounts of fat. So in that sense, the safe number that we have to have in mind is 150 cc's. We can approach gastrocnemius, most of the gastrocnemius, 150 cc's per side without increasing too much and going to baseline in 30 minutes. That is what actually we want to achieve.
So interesting you mentioned this. And is there risk of compartment syndrome in these sort of cases? What sort of volumes are you injecting into each of the muscle groups?
Mm-hmm. Well, the idea is that mainly upper torso doesn't have any problems. The idea is also we have some guidelines in terms of the volume versus the results. So we don't need to inject 500 cc's on a peg, even if you can, because it's going to look awkward. And the idea is to distribute the amounts of fat in different muscles to actually look okay, to look good. So we can say the pectoralis is the average is 150, the tops 250 to 300. The deltoid 50 to 100, no more than 100 cc's is enough, and usually it can lead to other complications. We didn't have a complication of having a compartment syndrome, but it starts to be painful in the post-op care. And there are some muscles, specifically the forearm muscles and the area of the calves, that we have to be very careful in the amount of fat that we inject. And in that sense, what we can combine it is with hybrid. So we can do part intramuscular, part outside in the subcutaneous tissue, so we can distribute it more evenly and having less problems of increasing the compartment pressure.
So we had a couple of questions from the audience again, and if you guys watching do have any questions, please post them and I'll try and get them answered. There was a question about what's the risk of fat migration or movement of the fat once it's injected, and then do you have any sort of long-term data in terms of what happens to the fat fat that's injected intramuscular, or what are the changes you see in a patient with time or with weight changes?
Mm-hmm.
Because they look amazing
Well,
on table, but what happens long term?
no, we have patients that we have follow-up of 15 years, and they tend to retain very good volume. They actually, oh, of course, they follow a aging process. So anyway, they're gonna reduce the muscular volume over time. But what we see is a very good retention. What we see is that part of this fat actually just blends in, you know. So usually these patients, when you do a CAT scan or an MRI, you actually see the stripes of fat still. We have been doing follow-ups up to a year, and what we see some stripes of fat, and what we see is something that is very difficult to prove because when you start doing when we start doing this in a patient and doing a follow-up, these patients actually start going to the gym because they actually feel better, they actually look better, so they start going to the gym. So there is no way to compare what happens to the muscle if they're actually gaining muscle because of the fat grafting or they're just gaining it because of the training. So what we devised is a system that actually is literally a way to compute these kind of things, and we actually call it the travel muscle. So usually the muscles that previously, before the surgery, patient had problems to gain volume, and that nowadays they are not so when we inject them. And I can say that 96% of these patients, they already have a way to say, okay, before the surgery, I could not gain muscle. And after this, I could gain muscle more easy. And when I train, I actually see the results more quick. So this is something that can actually be very helpful to prove in the long run, to say, okay, the fat that we inject, we suspect that we have um factors, growth factors and exosomes, and especially adult stem cells that are actually rejuvenating this muscle. Can we say that the fat is gonna, these kind of early, like adult stem cells can differentiate into muscle? I don't know. So it's something that we cannot prove. But Steve Cohen actually did an article actually about facial muscles, and they actually can show that the telomeres in the muscle actually regenerate and actually go longer. So, and they have other several factors that actually show that the muscle actually rejuvenate and regenerate after doing fat grafting. So what we suspect is in why not in bigger amounts of muscles and bigger muscles is happening as well.
And I had another question that was asking, does fat injections into muscle have any effect on their function at all?
Yeah,
That's interesting too,
amazing
because it
question.
works,
Yeah.
Actually, one of the other articles that we work in is what happens with the muscle strength after the surgery. And what they have seen is that they gain strength. They can lift more per unit of muscle than before. So the strength of the muscle is part of this biomechanics of the muscle, but it's part of the regeneration process of the muscle that we are seeing. How to prove it is a little bit more difficult, but it's something that when we do the surveys on the patients, all the patients actually relate to.
Right.
So if I
We
can,
are, yeah, go for it,
if I
Mario.
can
Yeah.
complement, I think where we are standing now is that we definitely have a strong clinical evidence
Mhm.
that the muscle is behaving in a better way after the surgery, after the intramuscular fat grafting. So there is a consistent evidence, clinical evidence of patients that are saying that regardless of age, that they are performing better in terms of exercise and in terms of specific muscle development. Sometimes muscles that they tried for several years when they were younger, that they were trying to develop without success. And after the surgery, even on their 60s, they are now reaching levels of volume of muscle that they didn't reach in the past. So this is the strong clinical evidence that we are seeing in the patients. Trying to prove this and translating this to science will be the challenge in the next years. But that is the game changer for plastic surgery, I would say. When we will be able to prove that fat has a function, an effect of increase of function of the muscles when they are treated with intramuscular fat grafting, this will be a game changer in terms of how we look to what we are doing actually for the patient. Okay. And we have the clinical evidence. As Alfredo was saying, this is hard then to publish and hard to prove. But I believe that maybe in a short period of time, we will be able to prove that there is a functional improvement of the muscle after the treatment with fat grafting. We have some settings already published in terms of reconstructive settings, in terms of the treatment of areas of trauma or treatment of muscles that were denervated, and that if treated with fat, that we have an improvement in the function of these muscles. So this has already been published. So it is normal to think that this could happen in the normal healthy muscle. There is a number of different then hypotheses that can be playing here. We can see an increase in vascularization after the intramuscular fat grafting. We can see paracrine function of the adipocytes or the stem cells. We can see differentiation of the stem cells into muscle. There are a different number of hypotheses, but none of this is science yet. We just have the clinical evidence.
Right.
If you allow me, Reza, the last message that I would like to say is that there is a strong message that I would like to translate here, which is this is not an easy procedure. Intramuscular fat grafting is not an easy procedure. Should be done with respect, and there is a learning curve. And Alfredo is doing this for many years. The ones of us that are doing this, we are doing this consistently every day for a lot of time, for a lot of years. And this is not an easy procedure. So I think the complications here can arise and will arise if we plastic surgeons think that this is easy and that we can start liberally injecting every muscle. But this is the same as every other technique of plastic surgery. We just have to respect the surgery.
Of course.
But I think you guys with your high depth liposuction have transformed how liposuction has been perceived. You know, it's you don't go in and spend half an hour doing liposuction, Mario. You have a detailed plan for the whole body. Are you, Alfredo? You know, you have a detailed plan for the whole patient. You have allowed the time to do that plan, and it's not an easy surgery. It's a very detailed surgery. It's a very well planned surgery, and the before and after surgery very well planned as well. And that's what's differentiating it into the procedure that it's turning into now, compared to quick liposuctions or fat graftings of the past. It's a totally different mindset and approach.
So we're coming to the end. I just want 2 minutes on advances. We talked a little bit about technology. What do you see as the hottest thing in technology available now? You know, Renuvian, J-plasma, BodyTite, quantum. So tell us a little bit about what you think is going to be the big thing in skin tightening and.
Well, I think we live in an exciting time right now because I think that technologies are very moving fast forward, very quickly and getting more and more efficient. I think this is the first time in history of plastic surgery that we can say that we can diminish the amount of scars based on technology that's do skin retraction. So I was part of the design team that actually built the quantum. Is part of my, I have the patent on the quantum itself, and it was a very hard idea to land. In some sense, actually it required, some of the emo geniuses that actually put it into works. But at the end, I think it works very nicely. It's a safe, efficient, and very fast machine. Doesn't need gas. And beyond that, I think we can approach the skin retraction in a different way. That we can do a very quick work, more that is more like I would say is more the mechanism of action of the Morpheus, but it's a fully internal device, And also, I think the future also goes with AI. We are actually also working in an AI for predicting specifically complications in body contouring. It's called Lisa. You can find it in the Apple and in Android apps. It's called Lisa Safety App. Lisa can actually predict the amount of bleeding that the patient can have based on very simple questions like the gender, the age, height and weight. So actually can determine the BMI and mainly the initial hematocrit or hemoglobin of the patient. With that in mind, we nourish this AI with 1,000 patients, and is very accurate in predicting what is going to happen to the patient, the thromboembolic risk based on the medical records of the patient. And it can give you like literally on-site like advice, let's say, okay, I think the patient is bleeding a little bit too much. What should I do, Lisa? And she can answer based on publications, based on evidence, the best choices and the nourishment also of all the years that we have been doing what we call the T12 system. That is mainly condensing all the approaches in safety and make them work together to increase the safety of the patients.
Amazing. Right. On that note, I think we need to wrap it up. So I thank everyone for joining us this evening, the speakers and the audience. I hope everyone found this very helpful and educational, and we'll hopefully have a few more Instagram lives in the future. So Alfredo, Mario, Nora, thank you for joining us at ISAPS, and we'll see you soon at a meeting, I'm sure.
Okay, thank you very much for the invitation.
My
Thank you.
pleasure. Thank you to
Bye,
be
everyone.
present.
Good evening,
Goodbye, everyone.